This is a stapler, but we're not talking about that right now. Yeah, you're in for a treat. Here we're going to talk about bladder disorders. Well, what kind of guy would I be if I didn't start bladder disorders with kind of the most common thing in the whole world, lower urinary tract infections? Medical term for that, cystitis, sac inflammation. Most common organisms causing cystitis, E. coli by far. Second and third place goes to Staph saprophyticus and Klebsiella pneumonia. Ladies, I know it's hard to be you. I know. I apologize. Hey, trust me, there's some stuff that guys suffer from more than you, so don't worry. Risk factors for UTI include that stuff. Can guys get UTIs? Yeah, they can. Their risk is lower, but yes, men can get urinary tract infections as well. Men who have indwelling catheters, chronic dehydration, diabetes, bladder cancer, obstructive uropathy, say from an enlarged prostate gland or benign prostatic hyperplasia, BPH. Guys can get it as well, just not as common. Now, if UTI is your suspected pathology, you're not going to know right away. You're going to have to rely on what your patient tells you. So ask the questions if they're not outwardly or they're too embarrassed to talk about it. Are they having urinary frequency, meaning they're peeing more often than usual? Is the urination process a process that is painful or have a burning sensation? Urgency means, I gotta go now. Get out of my way! Potentially blood in the urine. This is not always the case, but the inflammation involved in cystitis can damage enough capillaries within the bladder wall that some hematuria is found. Just a quick note, if the patient tells you that they've been having fever and other symptoms related to a UTI, as a clinician, especially we nurses, when we're kind of talking to people initially and triaging folks, if people have UTI plus a fever, that's a little bit more suspicious for a urinary tract infection that has grown up the kind of ureters and into potentially the kidneys. That condition is called pyelonephritis, and we will talk about it. Now, as your clinical suspicion for a UTI pathology is there based on what your patient is telling you, of course you're going to see a bit of a diagnostic workup to help rule in, rule out, raise suspicion or lower suspicion that you do have a UTI going on. Your two most common areas of clinical foci for a urinalysis include leukocyte esterase, an enzyme that white blood cells release when they're in the urine fighting an infection, and nitrites, which are a byproduct of bacterial infection in the urine. E. coli is one of the organisms that releases nitrites when it causes UTI. Did I tell you I love CAM? No, not him. CAM, complementary and alternative medicine. CAM is cool. And here's just a little bit of CAM-idnation about cranberries. I thought the article was very interesting. I'm actually not still 100% on cranberries' ability to prevent UTIs, but I do think it's a very interesting area of clinical CAM research. One of the reasons we treat UTIs is to prevent the development of something called urosepsis. Sepsis will always indicate someone who has an infection in the blood, aka a bacteremia, and they are symptomatic from it. Big fevers, hypotensive, massively ill. That's septic. Urosepsis denotes someone who is symptomatically bacteremic, and the origination of that process was the urogenital tract. The symptoms associated with urosepsis don't necessarily have to come from the bacteria themselves. They can come from endotoxins produced by certain strains of bacteria. Like many pathologies, our elderly are more susceptible to the effects and the consequences of this, so we need to take special precautions in that population. So contrast UTIs and urosepsis, both of which were symptomatic, with this kind of other thing, asymptomatic bacteriuria. As the name implies, no symptoms, bacteria in the urine. Huh! So here we have bacteria in the urine, but no urinary frequency, no burning, no nothing. E. coli is still the most common. Some strains of E. coli just don't cause symptoms. And the interesting thing about asymptomatic bacteriuria is that there's really no good clinical research to show that eradicating the bacteria has any long-term benefits. Some strains of bacteria, when they get into our bodies, are just harmonious. They're just kind of there. They're just doing their thing. And to give someone, antibiotics toward those bacteria at the potential risk of killing other necessary bacteria, especially in the gut. That's a big thing right now, the gut microbiota or the gut microbiome. Big news right now. To give somebody antibiotics unnecessarily, potentially harming the delicate gut microbiome, not a good idea. Not a good idea. Pyelonephritis. This isn't hard. Pyelonephritis most commonly is a UTI that took over the bladder, grew up the ureters, and then infected the kidneys. If it goes from the kidneys to the bloodstream, it has the potential to become urosepsis. So let's follow this on a sequence of pathologies. Urinary tract infection. Overgrowth leads to pyelonephritis. Further growth leads to urosepsis. See how you can kind of follow this sequence of pathologies anatomically? And with each stage, things are getting clinically worse. Classic presentation for pyelonephritis is something called costovertebral angle tenderness. You'll learn about this in assessment. I'd like to emphasize it here so it's really hammered into your brain. The costovertebral angle is where your rib cage in the back meets the backbone. That's the CVA, the costovertebral angle. When you're assessing for tenderness, guess what you're doing? Does this hurt? Actually, that's not what you're doing at all. It's one tap to the CVA. It's not. You're not hammering on anybody. That was wrong. Totally wrong. Erase that. CVA tenderness, along with a lot of the other clinical signs of UTI and systemic signs like fever and chills. So pyelonephritis is one step worse than a UTI, and will have more of a workup than a UTI will. UTI, a lot of you guys are going to see this in your primary care office. You're going to see the patient given antibiotics without necessarily knowing exactly what bacteria is going on down there. In pyelonephritis, a little more serious clinical picture. You're one step away from urosepsis, so the workup is a little bit more involved. There may be intravenous pyelogram studies done, kind of looking at the structure of the collecting ducts and the drainage areas of the kidneys. There may be imaging done in the form of a CAT scan and ultrasound. Of course, urinalysis and urine culture as well. These people are definitely going to need some antibiotics. They're going to need fluids to make sure that the kidneys and the nephrons are getting adequate amount of fluid. If there's an obstruction, that will need to be relieved as well. The take home here is there's a little bit more workup involved in your typical pyelonephritis patient because this is, a couple degrees more severe or more potentially morbid a clinical situation than is just your average UTI. So I don't really have that much to say on urinary incontinence, so hold on, I gotta go. Phew! Oh, jeez Louise. Okay. What was I talking about again? Oh, yeah, urinary incontinence. Lots of things cause urinary incontinence. Some of them are completely non pathologic, some of them are. Patients with diabetes, neuropathy, or the destruction of nerves, including nerves that innervate the bladder for bladder coordination and for proper voiding, can be lost over time. When we talk about spinal cord injuries, the loss of nerve function to the bladder would present or give a pathologic example of a source of potential urinary incontinence or urinary retention. For men, prostate cancer and benign prostatic hypertrophy, BPH, can create a whole range of different urinary symptoms. Incomplete emptying, incontinence, pain, all kinds of different things that are specific to how the prostate gland is growing. Remember from A and P that the prostate gland has right at its center the urethra going through it. So if that prostate gland is getting bigger at the center, it could squeeze the urethra closed. And again, based on the way it's growing and based on the way it's squeezing the urethra, you can get all kinds of different urinary symptoms. Stress incontinence. Well, what other kinds of incontinence are there? Overactive bladder. Oh, I always have to go. Overflow incontinence from chronic overdistension and then retention of the bladder and then urine spilling out from there. When we talk about spinal cord injury, we will talk about neurogenic bladder and the loss of innervation from spinal cord injury. We'll also mention it when we talk about diabetes. Maybe the Now, kidney stones kind of bridge the gap, so to speak, between bladder and renal pathologies because they, can start in either or place and can travel. And they travel. They travel down typically, but kidney stones travel.
Kidney stones are hard stone-like lumps that can form in your urine. They are common and occur twice as often in men as women. Let's look inside the body to see how the kidneys work. The kidneys are two bean-shaped organs located near the middle of your back. They work as a filter, removing waste products and excess fluid from the blood, and returning clean blood to the body. The waste products and excess fluid become urine. It travels through two narrow tubes called the ureters to the bladder and leaves the body through the urethra. If there is an imbalance in the waste chemicals in the urine, crystals can form, which may build up into stone-like lumps. These are known as kidney stones. This can happen for a number of reasons, including not drinking enough water, a diet high in protein, or health conditions such as kidney disease. If kidney stones are small, they usually leave the body when you pass urine. However, larger stones can get stuck in the kidneys or pass down the ureter, causing irritation and blocking the flow of urine. This often results in an infection and intense pain that is felt in your back. Kidney stones can sometimes be treated with fluids and painkillers. However, if infection develops or the urine flow is obstructed, further treatment may be needed. Your doctor will advise the treatment best suited to you. In shockwave therapy, shockwaves of energy are used from outside of the body to break up the stones into small pieces that can be passed out of your body in urine. In percutaneous nephrolithotomy, a small cut is made in your back, and a thin telescopic tube is passed into your kidney. The stone is then either removed or broken into smaller pieces using a laser. A ureteroscopy is used if a kidney stone is stuck in your ureter. A thin telescopic tube is passed through your urethra and bladder and into the ureter. The stone is then either removed or broken into pieces with a laser. If none of these methods are suitable, the stone may need to be removed using traditional surgery. If you've had a kidney stone, there is a risk of getting another one at a later stage. Your doctor will be able to advise you on medicines and changes to your diet that can help prevent further stones.
Nephrolithosis is most common in the renal pelvis or the calyces of the kidneys. Approximately renal calculi or nephrolithosis, most of the time made up of a calcium base to it, less often struvite and uric acid. Uric acid, remember, is the one of the end products of purine metabolism when DNA is broken down. Also one of the hallmarks of patients with gouty arthritis who develop uric acid crystals within joints, most commonly the big toe. Why do people get kidney stones? Maybe there's a change in the pH that facilitates precipitation of minerals into stones. Infection is known to change the pH of urine. Urinary stasis, whenever the liquid basically isn't moving and remains static. Dehydration can cause this as well as immobility, obstructions, and perhaps metabolic processes. Hyperparathyroidism is a great example. In hyperparathyroidism, people have a high blood calcium level. This can manifest as calcium-based kidney stones. In gout, people can have elevated uric acid levels. This can manifest as uric acid-based kidney stones. Regardless of the makeup of the stone, kidney stones hurt. They hurt. The other interesting thing is that when patients come in, this is for you ER nurses, when patients come in with kidney stones, one of the hallmark features is a migration of the pain. So let me give you a clinical example. Patient who comes in and says, I woke up in the middle of the night with flank pain or CVA pain. It started right back here, but now it's moving down here, and now the pain's right here. Oh, it hurts so bad. Oh. Pain that's moving and causing radiation and traveling and whatnot is classic kidney stone pain. Add to that other systemic signs like fever and chills and things of that nature, and you've got something that looks like a kidney stone, walks like a kidney stone, and probably is a kidney stone. You will definitely see workups to rule out other conditions. And if the stone can be caught, because these people will be asked to drink and to strain their urine, if the stone can be caught and the makeup of the stone can be diagnosed, it's possible that lifestyle changes may be able to thwart the growth and potentiation of another stone in the future. Take a uric acid stone, for instance. If the stone's made of uric acid, you can just advise your patients to stop eating DNA. Well, DNA. Yeah, DNA is broke down to purines. It's the low purine diet. Yeah, no, I didn't make that up. That's old. I mean, if you tell patients to eat a low purine diet, isn't that you're just saying, stop eating DNA, blah, blah, blah. Ugh. Treatment for kidney stones really rests upon fluid movement breakup and putting out the stone itself. If that doesn't work, there are other approaches that can be done. Lithotripsy, which is shockwave therapy, nephrolithotomy, which is actually surgically going in and removing the stone. There's other things that can be done. Easiest, cheapest, least complicated is fluids and peeing it out. Now, kidney stones are bad news, and there are complicating pathologies that can come from them. For example, these calculi may damage the renal tissue or the parenchyma of the kidney long-term, causing nephron dysfunction. In addition to that, their obstructive properties. The obstructive properties of stones can cause hydroureter and hydronephrosis. Both of those terms mean water on the ureter or kidney. Places water should not be static. Water should be draining out of continuously. A hydronephrotic kidney cannot filter appropriately the blood. I mostly threw interstitial cystitis into this presentation because of its mysterious qualities. Interstitial cystitis is an as yet to be identified pathology. We know what it is based on its clinical presentation. We know what people subjectively tell us, but we don't yet know what exactly is going on from a pathophys perspective. Isn't that crazy? To wrap up the bladder talk, I do like to just kind of name drop a couple terms, diagnostic studies and stuff that you're going to hear, and it's good to get repeated exposure to. For example, a KUB x-ray is a common medical term for an x-ray of kidneys, ureters, and bladders. So if that's written in a patient's chart and it says CUB, that's what it stands for. An intravenous pyelogram is a study of the kidneys and the collecting ducts of the kidneys themselves. It involves using a dye, so patients need to have adequate renal function to get this test. An angiogram of any part of the body, including the kidneys, is simply a visualization of the blood vessels of that particular target area. And then, of course, there are ultrasounds, CTs, and MRIs, magnetic resonance imaging. Direct visualization of the urogenital tract starts at the level of the bladder with the insertion of a fiber optic camera into the bladder to look around and inspect the bladder itself. And that clinical term is called cystoscopy.